Before we dive into discussion, can I ask for a volunteer from the group to report back after we're done? I'll take notes and we'll show our notes on the screen when we get back to the full group, but we want a council member to do that.
It's a funny thing. This is not a shy group, but everybody's being shy right now. I would prefer not to, because I don't want the DHHS person doing this. So if someone else would mind jumping in, that'd be great. Or we'll draw straws.
I'll report back.
Thank you.
Perfect. Okay. And I'm just gonna note that on my sheet here. Okay, so I'm gonna share my screen so we can get these up. Let's see here. Share screen. Okay, can everybody see that? Perfect. So again, these are the, and let me make sure I can get it. Try to get everything on one screen here. Maybe I should try to make it smaller. We can go one by one here, but again, there's 9 topics. The primary goal here, again, is to react to these strawman guiding principles that are supposed to be avenues that the group can pursue to address how to achieve increased access and coverage of healthcare services for North Carolina's uninsured population. So we really want to talk about these guiding principles, figure out what we want to prioritize as a group. We're not really getting into policy options within each particular principle, but again, just as a reminder, sort of what are your general reactions? What are items that we've discussed during the council meetings to date that may be missing? Are there principles listed here that should be prioritized over others? Is there anything on this list you think that should be removed or does not represent our conversations? So I will just briefly introduce the topics. Actually, no, we already did that. Amy did that. So I'll just open it up to the group. I don't want to take too much time talking here. What jumps out at you right off the bat? What are your first reactions?
Well, I mean, I'll just go back to what I said earlier on, which I think access to affordable healthcare coverage has to be foundational. And then within that context, the solutions that we come up with should address, these guiding principles. It has to involve efficient use of taxpayers' dollars. I don't think there's a question about that. Relief for employers, particularly small businesses, health system sustainability, or I would also maybe say it another way, do no harm at a minimum. It has to expand access to mental health services, but not just mental health services, mental health parity, which is critically important. And then, our rural communities, I would expand that a little bit more to, it's all communities, because even in our urban communities, we have challenges. So I would say that we just need to make sure that it addresses rural, urban, suburban, but also from a population perspective, populations that, irrespective of socioeconomic status, race, or ethnicity. So, and just one comment I would make about health system sustainability, because there's a piece here that's not explicit, but maybe we could put it under health system sustainability, I don't know, is around costs, because that's not explicit really in terms of opportunities to drive down medical costs and pharmacy costs and costs in the system in general.
This is Margaret, and I would agree with all that was just stated. I think certainly it is important and fair for us to look at all of the options for access to coverage, but I think, as I said in my last, in the last meeting and in my comments, and I'll continue to say, I think we really do have to continue to prioritize and drill down the importance of Medicaid expansion and really do the deeper dive of what that will mean in terms of and covering more lives. And in doing so, I think that addresses a number of the issues that we've discussed today and previously. It's not, the be all end all, but it certainly is a game changer. And someone mentioned earlier that we don't yet know what President-elect Biden will say once he takes office, but I'm certainly hopeful that there will be some incentives and some stronger consideration to push forward Medicaid expansion. So I just hope that as we look at access to coverage and as we look at those options, and I know that there are several of them, that we really do drive home the fact that Medicaid expansion will address so many of these critical issues in making sure people get coverage.
If I could jump into Tunde's point about the access to coverage piece being really foundational, I absolutely agree with that comment. I do really think that that is the foundational piece here. And as I think about, our work in rural communities, and he's also absolutely right, problems exist in urban, suburban, and rural communities across the state. It is, we're an economic development organization. That is our focus. So this foundational piece of closing the health insurance coverage gap and getting more people covered is fundamentally about how do you build a stronger rural economy for us. And I think that translates across the entire state to how do we build a stronger economy for the state of North Carolina. And I really believe it is the case that you cannot do that when you've got 1.2 million people without health insurance coverage. And so it is foundational in that sense. It is a path to building stronger economic vitality across the state. I also accept the idea that there may be a range of options or a combination of options that may ultimately play into our solutions, and I'm very open to that. However, I do think sort of a cost-benefit analysis needs to be applied to each of those options. What rural North Carolina and rural North Carolinians can't afford is solutions that are incremental. We cannot continue to make incremental progress, and I would argue that we probably aren't even doing that in recent years. We've really got to look at options that in some scalable way address the access to coverage issue.
I'd like to address it a little bit from a workforce issue. I have the lens of being not only a pediatrician and a provider, but a medical educator, having trained thousands of students, a residency program director, and now as director of the GME programs at UNC hospitals with over 1,000 trainees. I have seen through the years how we have trainees that would actually, and who have a heart to go to underserved areas, regardless of whether they're rural or urban. However, the lack of opportunities there. And so part of that is because many of them want to serve in either FQHCs, which are the federally qualified health centers. It is nearly impossible to find one of those and a job upon completion of your training. If we don't have practices or incentives to actually go to these areas that involve loan repayment, no provider is going to want to go to these areas. And so in addition to providing expansion of coverage, there are some very innovative ways and things that we can do to actually incentivize trained providers to serve in underserved areas, whether they're rural or urban. And that is incredibly important. I know we've talked a lot about expansion of providers that can do this, but it's not feasible. It's not economically feasible to do that if the jobs are not available, or the means to provide the healthcare isn't available. So I would emphasize a way for us to actually look into programs that would do that, and especially include pipeline programs so that we have providers who are from these communities, who want to go to health profession school, whatever health profession that is, and return to these communities and serve. As of right now, those options used to be robust, over a decade ago, and they are dwindling now.
My thoughts and reactions to the guiding principles, I think they're good in terms of conceptually. I know it takes a longer time to write a shorter story, and maybe we don't have that time, but I think it is so much to chew off of. It needs to be like consolidated or brought down. I think some of these things could be combined and get the same point across, just when people are trying to deal with the problem. And if you have 5 versus 10, I think it would go a long ways in terms of keeping us really focused.
So Reginald, thank you for saying that. I was wondering why access to coverage and affordability of coverage are 2 different bullets, why you wouldn't have one principle that says access to affordable coverage and just combine those. I mean, it is absolutely pointless to increase access to coverage that's unaffordable, right?
Right.
So that was one thought that I had. And another thought that I have, and I'm not sure I have a recommendation for a change in a bullet. I don't want to do anything that would dilute the urgency or the importance around strengthening rural communities. Healthcare being, the rural communities are so adversely affected by all that health economic activity leaving their communities and going into the urban settings. We obviously need more affordable coverage, so that supply will follow the demand back into these rural communities, just as was mentioned about opportunities to work in FQHCs in rural communities. Well, if the FQHC in the rural community is not financially sustainable because it doesn't have enough covered lives, then it's just a downward spiral. So I don't want to do anything to minimize the importance around strengthening the rural communities.
And this is Kristen. I think I would just, can you hear me? Yes. I would just add to a couple of those comments in terms of rural areas and what we're able to provide, that, those federal Medicaid dollars are only drawn down when services are provided to patients. And so I think that's, part of the consideration that maybe we haven't talked about as much is, no matter, even the eligibility increases, the numbers of people we've seen increase like over the past 15 or 20 years onto Medicaid, as the providers are not taking on those patients and those patients are going to the ER, we need to be careful about how we're actually going to give the service we're intending to provide. So just kind of piggybacking on to both Kenya and Casey's comments.
I was trying to unmute myself. I couldn't do that very well. Dave, I think that the comments are terrific, and I love the idea of consolidation. And I think Representative Baker, as you described it, said that workforce development, as we've talked about, must be a part of all of this, right? And we have to make sure we're integrating that as this effort. I want to say just a quick word about the the efficient use of taxpayer dollar, because I think as I've been, in and around as people have these conversations a lot, I believe the part that gets, I don't know, let me take a step back. I don't know anyone that isn't for, providing better coverage or clearly better healthcare for people in this state. I think we all come around as principals. That's why I think some of the high levels will be really easy to get to. It's then how do you make decisions about what's the most efficient use of taxpayer dollars? I think what I'm hoping is that as we talk about that principle, is that we're looking at it as that taxpayer dollars both at the federal and state level, and how do we as North Carolinians really focus hard on what's best for our state and how we make that happen. So I noted a lot, and we've obviously looked at these slides a lot when we think about some of the things that we all know we want to do around supporting pregnant women. But how do we make sure that we do that, and let's not do that at a greater expense of supporting larger groups of people. And I want to add, because I don't think we have any folks from like the Association Health Plans represented in here, is I think as we're thinking about this, there'll be pros and cons to every approach we have, and I think one of the principles ought to be is that we don't let the the great be the enemy of the good, right? That we look at all these options and try to figure out what are the best that we can come up with, and not get stuck to where we wind up fighting over small details, or that's one way to say it, arguing over small details. But what we really want to do is make sure we're looking at what's best for the state, and I suspect whatever ultimately comes out of these won't be perfect, but what we really want is something that addresses as much as we can those coverage issues in North Carolina.
Just flagging for the group, we have about 9 minutes left. Any topics on this list? I know that it's hard to get all this on one screen. I'm going to scroll down for a bit. Any topics you all see here that you think should be prioritized or deprioritized that we have not talked about yet, or stricken from the list or added to the list? Try to get it as big as I can on one screen. I think this is everything besides the access bullet.
I know we
but
did.
No, Kenya, you go.
I know we talked, and we have a bullet there about expanding access to and coverage of behavioral health services, but I just can't underscore. I just can't underscore that enough. Our country is, but our state is in a crisis right now. And every morning I wake up on a 7 a.m. call for our COVID response. And our numbers are the highest we've ever been. We're about to declare an emergency pandemic status for our trainees at our healthcare system. And consistently, our behavioral health ED is beyond capacity. It is beyond capacity. And if anyone has ever visited any behavioral health ED, no one would want to be in there. Whether you were going through a mental health crisis or not. And it is getting worse. And what I have found as I've cared for these patients is it's the last resort. That's where they're going, is to the emergency departments. And the emergency departments are not equipped to care for them. There is no inpatient placement. And there really is very minimal to no outpatient resources. So I just can't stress how the level of crisis we are in this state with mental and behavioral health services and parity. There are so many preventable deaths occurring right now from mental health and behavioral health. I would have that be just an absolute priority. In all that we do, integrated in all that we do.
I also agree that is a point that should have added emphasis. I agree with her that I don't think it can be overstated how big a problem this is right now.
And I would just agree, not adding any more than what was already so well stated, but just highlighting that this is critically important as a behavioral health care provider, we've seen the increase in numbers of those needing help, especially since the pandemic. And so I do hope it is a priority and appreciate that you've noted such.
So just going to all those points, and I think Reginald made the earlier point about consolidation. As I look at some of what's here, so spiking out behavioral health. So what would be the solutions? Obviously coverage, which is foundational, we've talked about, but that's where telehealth / broadband access now comes into play. Yeah. That's where, what you referenced, Kenny, about, incentives for providers, whether it's to practice, in health professional shortage areas, rural areas, and so on, where we know it's even more dire with respect to access to BH services and so on. Healthcare professionals, and I'm not sure what the law calls for in North Carolina since I'm relatively new, but being able to practice at the highest level of licensure and so on, so that it's not just coverage, but you're also providing an environment for access, true access to services.
This is Dave again. I think I think the idea of consolidating the principles makes a lot of sense, because I think people won't pay as much attention to 10 of them as they'll do 5. I think that makes great sense. And my sense is that I'm committing due to this, but they're pretty good at that, is that as we come back and report out, I think helping from all of the groups to do that consolidation and to get something back for us to look at that will be manageable. The part that excites me a little bit is of all the things that we're talking about is that, what we're hoping obviously is that with these principles, that gives our members of the General Assembly something that has this broad base of community support around those principles to work on. Because I think, behavioral health changes will require legislative action on certain areas. And obviously broad coverage requires that. I also think some of the workforce issues requires changes in legislation. So I think it puts it in place to where you've got this consensus growing of people of what these priorities are, that we can all help our members of the General Assembly think about those. And Representative Baker, I don't want to put you on the spot, but I'm hoping that's something that thinking about it that way allows you a tool to work with your colleagues on.
Definitely, yes. No, I appreciate that. I think that's a really good point, that if we're going to make movement, it is going to require legislation in certain areas. And, I think it's tricky. These conversations are tricky as we're looking at, one thing we haven't talked a lot about is Medicaid transformation, and will that impact any of these numbers like that were presented this morning, things like that. I think that's going to be, speaking as a legislator and going into this particular year, I think that's going to be something that's going to be an additional challenge, is to look at how to, kind of coalesce, so having the big ideas is critical, but then maybe coming back, I felt like this presentation this morning was exceedingly helpful to have those numbers, but my thought is, oh gosh, now, how does transformation impact that? So.
And just know that we're committed to making sure we try to figure out how to put that in a concise approach so that you can see what those look like. Yeah, but that's right.
I have a question or a thought that I just want to bounce off of you, and it's not a recommendation, but I wonder, Tunde made a comment earlier. I heard him briefly say that, we should have a principle of no harm. And I don't know how we would capture that, but at this point, a lack of decision, a lack of action could actually result in further harm. We could actually, if we fail to do anything, if we fail to take action on any of these options that are in front of us, we can see things get significantly worse. In just a personal anecdote, this past Monday, we just opened our behavioral health crisis unit. We just opened a 14-bed crisis stabilization unit. And, you know, and immediately we were able to unload our ER. To Kenya's point, our ER was full, and we were able to get some people to bed, get them fed, and get them some medicine and get them into treatment. But the pro forma for that unit is not sustainable unless we get coverage for that population. So fail into act could actually have it could result in harm.
I certainly
That is
agree.
outstanding, Casey. Oh my gosh.
Amen.
I think just to recap, we may have less than a minute here, so quick thoughts.
I was just going to say that I agree with what Casey just said, and I think that that reiterates what Reginald said as well in terms of not having so many options, but really narrowing down so that we can come up with some options that we can work on and see something achieved from it, and not just continue to be discussed.
I agree. If we can have a focused timeline, I'm about getting things done versus about talking about them for a while. So identifying barriers that would result in just grinding the wheel versus things that we can implement and how we can prioritize what we can implement feasibly soon.
And I'm desperately trying to consolidate and organize the conversation here to help you, Dr. McNeil-Trice here. But so hopefully this will tell a story, trying to highlight and organize and all that. But
Are you going to share that on the screen when I have to report back out?
yes, this will be on the screen. So you'll. Is there anything we've missed?
I think this was a good group. Maybe we were all profiled to be together. I don't know. It's a good group. I like this group.
I suspect all the other groups are saying the same thing. I sure hope so. Yeah, it's good. You guys are terrific.
Okay, I think I have it almost to a single page. I'm going to delete the discussion bullets, I think, unless people want me to leave them up.
That's fine. You're just going to include what we talked about. That's good.
Yep.
And can I just, I don't know how you're gonna collapse it, but just telehealth being in there, I don't know if that got into the discussion.
It's currently under expanded access to mental and behavioral health services, but we can pull it out.
Perfect. Okay. Thank you.
No problem.
It actually applies to quite a few others, like for example, strengthening our rural communities. Well, maybe in this COVID world, it's now across the board, but even more so.